are talking today about basic electromyography. My lecture is divided into two main parts. First, spontaneous activities, and the second part will be the motor unit action potential measurements. We will take a few minutes to recall basic knowledge. As we all know, the lower motor neuron pathway has four main stations. First station is the anterior horn cell. Second station is the peripheral nerve. Third station is the neuromuscular junction. And the fourth one is the muscle fibers. Each station has characteristic finding when there is a lesion in it. And this finding can be recorded by the electromyography. To do a proper EMG examination, we have to prepare my patient. First, I have to insert the needle electrode into a completely relaxed muscle. In this relaxed muscle, I will assess insertional activity and spontaneous activity. Then I ask my patient to contract his muscle mildly, and I will assess for the motor unit action potentials. And the last or the least one is fully contracted muscle to assess for recruitment and interference pattern. Few basic knowledge. This is the needle electrode, and this is the muscle fiber. Here is the end plate site. Here, where the action potential starts. But we are not recording from inside the cell. We are recording the extracellular changes or the extracellular reflection of the action potential. As we all know, there is resting membrane potential in which the inside of the cell is relatively negative in relation to the outside. With depolarization, the inside of the cell became relatively positive in relation to the extracellular fluid. In another way, the extracellular fluid is relatively negative in relation to the intracellular fluid, and the needle electrode will record this negativity. In electrophysiology, negative potentials means upward deflection, and positive potentials means recording needle electrode will record, and upward deflections means negative potentiality in the extracellular space. Okay? Okay. To record insertional activity and comment upon it, we have to put the machine in the proper parameters. Sweep speed and sensitivity. Sweep speed, 10 milliseconds per division. This means each horizontal division equal 10 milliseconds. And the sensitivity, 50 microvolt per divisions. This means each vertical division equal 50 microvolt. If I put the sensitivity 1 millivolt per division, I will miss the insertional activity. They are so small, I have to put the sensitivity in the lowest, 50 microvolt per division or less. In response to needle electrode puncture of the muscle fiber depolarize in a brief burst of several hundred milliseconds. This muscle fiber depolarization, I will record it as a upward deflection, as a negative potential, as I am recording from the extracellular space, not from the intracellular space. If insertional activity is prolonged more than 300 milliseconds, this is recorded abnormality. Is this the insertional activity? No. This is the artifact introduced by the insertion of the needle. This is the insertional activity. Very brief, monophasic, small in amplitude and short in duration. And I can record it in response to needle movement. With each needle movement, insertional activity will reappear. This is another example of the insertional activity. This is the movement introduced by the needle insertion, and this is the insertional activity. If it is prolonged, This means abnormality. So electromyography, as I mentioned before, relaxed muscle for spontaneous activities, mild contracted muscle for motor unit potentials, and fully contracted muscle for interference pattern. Let us start with spontaneous activities. We have rule in electrodiagnosis. All spontaneous activities are abnormal except that recorded from the end blade potential, end blade region, or neuromuscular junction. The potentials recorded from the neuromuscular junction, either end blade noise or end blade spikes. Some basics again. This is a muscle fiber. This is the nerve twigs, and this is the neuromuscular junction or synaptic cleft, and this is the recording electrode. As you see, the recording electrode is outside the cell. Depolarization occurs here, and I am recording the extracellular fluids. Due to puncture of the motor end blade by the needle electrode, or let me be more specific, due to puncture of the muscle fiber at the end blade potentials by the electrode, miniature end blade potential produced. This miniature end blade potentials is not propagated, so it is only localized to the end blade site. And this is called the end blade noise. As we see here, end blade noise is monophasic, negative potentials of low amplitude, fire irregularly due to miniature end blade potentials. These are miniature end blade potentials. And this is normal. If I just remove my needle from this side and minimal adjustment, it will disappear. What's the difference between end blade potentials and end blade spikes? End blade spikes is due to depolarization of a single muscle fiber, not miniature end blade potential. It reaches the level of the action potential, but for a single muscle fiber. So it is brief, biphasic, with initial negativity, but still of short duration and small amplitude, and fire irregularly. Fire irregularity is an important differentiation between end blade spikes, end blade potentials, and fibrillation potentials. The difference between spikes and fibrillation potentials, one of them is the rate of firing. Due to terminal axonal twigs depolarize and a single muscle fiber action potential appear. Here is end blade noise due to miniature end blade potentials, and here combination of end blade noise and end blade spikes, miniature end blade potentials, and muscle fiber action potentials, single muscle fiber action potentials. All have negative beginning, upward deflection. Spontaneous activities, abnormal spontaneous activities, has two main sites to appear from or to originate from, either due to abnormality in the muscle fiber or due to abnormality in the motor unit potential as a whole. Abnormality of the muscle fiber, the most common is fibrillation potentials, positive sharp waves, complex repetitive discharges, and myotonic discharges. Abnormality from the motor unit as a whole, the most famous is fasciculations. We'll discuss each one of them in shortly. Fibrillation potentials. Fibrillation potentials are brief spikes with initial positivity. This is difference number one, initial positivity. Very regular firing rate. This is difference number two. To differentiate end blade spikes from fibrillation potentials, freeze the screen and look what is the initial deflection, positive or negative. Let the screen in the normal way and regular firing or irregular firing. Positive waves has the same features, initial positivity and a long way negative phase. And again, it is a regular firing. This is fibrillation potentials. As you see here, initial positivity, biphasic with initial positivity, all of them, and regular firing. Positive sharp waves, initial positivity with following slow positivity, negativity, sorry. This is another example. This is fibrillation potentials, and this is positive sharp waves. This is an, okay. I hope this is working. Very regular, very, very regular. Positive sharp waves appear with alternating fibrillation potentials. Let's imagine we hear the sound of the fibrillation potential and the positive sharp waves. Here, the sound is very important in myotonic discharge. Myotonic discharge due to irregular firing of a group of muscle fibers spontaneously, start irregularly, and later on they increase in frequency and speed to become waning, waxing, then waning, waxing, then waning. And a very characteristic sound for myotonia. It looks like the dive bomber. No one of us hears the dive bomber. This from the World War II. Now it is the most like motorcycles when boys play with motorcycle in the streets and make the sound woo, woo, woo. This is the sound of the myotonic discharge. Because here, this is the picture when we freeze the screen, myotonic discharge with waxing and waning, waxing and waning. I hope you can hear the voice here, the sound. Did you hear the sound of the myotonia? I hope so. This was an example of the complex repetitive discharge. I hope you can hear it. I will let all the videos play again at the end of the lecture. Now, if we can, we talk about the spontaneous activity from the motor unit potential as a whole. The most famous of them is fasciculation. Fasciculation are very slowly and irregular discharge, about 1.1 to 10 hertz. And this is a picture of the fasciculation. It is like motor unit action potential. It is motor unit potentials, but firing at a irregular firing, when large, very large, about 3 millivolt per division. So I can see it as completely obscured my screen. This is another picture of the fasciculation potentials. Okay, this is my first part of the lecture. Now I'm going to the second part, which is motor unit analysis. The number of muscle fibers per motor unit varies according to the size of the muscle. If you have a small laryngeal muscle, number of muscle fibers from 5 to 10, huge soleus muscle, which carry our weight, it will be hundreds of muscle fibers. Territory of the muscle of the motor unit is about 5 to 10 millimeter in others. What we mean by territory. If we draw a circle with a diameter of 5 to 10 millimeter, about 1 centimeter, half to 1 centimeter, the number of muscle fibers within this circle called territory. And we have a multiple of territories overlapping. So it is very rare to have two muscle fibers related to the same motor unit as near to each other. Is this okay? We mean by territory, we draw a circle including the muscle fibers within 5 to 10 millimeters. Territories are overlapped, just like this. Many territories, and if we look like to the muscle fibers beside each other, they are not related to the same motor units. Another basic knowledge, this is the territory. And this is the muscle fiber inside this territory. If I draw another circle here, this muscle fibers is not related to the same motor units. This is the motor unit and the axon. Motor unit, the axon, the nerve twigs, neuromuscular junction, and this is the muscle fiber. Here, the needle electrode. When the action potential starts in the motor unit, reaching the neuromuscular junction, each muscle fiber will depolarize at a different time in relation to the recording tip of the needle. First one will produce this action potential in a very good amplitude. The second one has smaller amplitude, different amplitude. The summation of all these amplitudes of action potential from different muscle fibers will produce the motor unit potential appear on the screen. So the motor unit potentials is a summation of action potential of different muscle fibers related to the same motor units. Okay? Okay. The size of the motor unit related to the size of the axon, the speed of conduction of velocity in this axon, to the myelin sheath of the axon, and the metabolic type of the muscle fiber. We have two metabolic types of muscle fibers, type 2 and type 1. Type 2, the largest motor unit, and type 1 is the smallest motor unit. Type 1 is the one initiating with mild contraction of the muscle. So mild contraction of the muscle, I am recording type 1 muscle fibers action potential. With maximal contractions and interference pattern, I'm recording from type 2 muscle fibers action potentials. For each motor unit action potential, I have to comment upon morphology, stability, and firing rates. By morphology, we mean duration, amplitude, and phases. The horizontal line for duration, the vertical line for amplitudes, the number of phases crossing the horizontal line. So for duration in millisecond, from starting of initial deflection to the return to the baseline. From here to here, I measured duration of the motor unit in milliseconds. For amplitude, peak to peak. And this is recorded in millivolt or in microvolt. From peak to peak. Number of phases which crossing the baseline. This is crossing the baseline, this is phase 1. This is crossing the baseline, this is phase 2. And this is crossing the baseline, this is phase 3. What about this? This is called serrations and not counted as phases, not calculated as phases. What about this? This is called satellite potentials. Satellite potentials means repolarization of action potential. Depolarization produced motor unit and repolarization produced satellite potentials. Okay? So for each motor unit, I have to measure duration in milliseconds, amplitude in millivolt, number of phases. Okay? This is territory, motor unit territory, and this is the muscle fiber. For simplification, we are talking all of them as one territory. This is a lot of muscle fibers, but the recording needle electrode is not teaching except one, touching one. The others are away. So the amplitude recorded is small. When the tip of the needle electrode touch muscle fibers by tip, larger amplitude. When the tip touched 3 muscle fibers, larger amplitude. So amplitude depends on needle position. Needle must be very near to a group of muscle fibers to record a good amplitude. So you have to change your needle. Different, very simplified movement to reach a group of muscle fibers to have the largest amplitude of the motor units. Okay? Phases means synchrony. Synchrony, how many muscle fibers are depolarized at the same time. When a lot of muscle fibers depolarize at the same time, this will produce good action potential, good motor units with minimal phases. If the muscle fibers diseased due to nerve injury or nerve lesion, so the time taken by each muscle to depolarize is different from the next muscle. The action potential reaches the tip of the needle at different speeds. These speeds will lead to many phases. We called it polyphasic motor units. Synchrony is a good, this is a normal. Muscle fibers are in synchronous, in harmony. If they are not in harmony, each one will contract at a different time, and this will produce multiple phases or polyphasic motor unit potentials. This is the serrations, not crossing the baseline, and satellite potentials means re-innervation of the muscle. This is tips. This is the needle. The very near circle represents the amplitude. The blue circle represents the phases, and the light blue circle represents the duration. So the most important, depending on needle position, is duration. Duration depends on needle position about 1 millimeter from the tip of the needle, and it is markedly affected by the position of the needle. Amplitude is markedly affected by the position of the needle. The least affected by the position of the needle is duration and phases in between. So amplitude markedly depending on the position of the needle. Duration is the least to be dependent on the position of the needle, and phases in between. Okay? This is another video. I hope you. This is a normal motor units with mild contraction reaching to maximum contraction. Another time. Now I'm reaching the end of my presentation, and I will try to share the videos once more